Hello, everyone, and welcome to AAKP's Policy Summit, Patient Voice, Patient Choice, New Determinants for Kidney Policy. I'm Richard Knight, Immediate Past President of the AAKP. On a personal basis, I'm a former dialysis patient and 16 years out on my kidney transplant. Professionally, I work as an adjunct professor teaching courses in management and business strategy. Much of my background is in the public policy arena, working at congressional operations based on my experience on Capitol Hill, where I served in various roles including communication, policy, and as a legislative director. While working in the U.S. House of Representatives as a top aide to a congressional leader, I had the privilege to serve as liaison to the Congressional Black Caucus and was involved in significant policy work with the House Energy and Commerce and Small Business Committees. These experiences have provided me with a framework and a background with a valuable set of skills that I've put to use for AAKP on kidney policy issues over the past decade. However, you do not need to be a professional policy expert to get involved in the policy process. You simply need to be an informed patient. Take the time to study important issues that affect you and your fellow patients, and take advantage of AAKP's free online advocacy engagement skill development training programs. Your voice and your vote can lead to important changes. If you are not a member of AAKP, please join us. Our membership is free. Just go to the link shown at the bottom of the page and sign up today. Furthermore, I want to encourage you to sign up for AAKP's alerts to AAKP's Action Center at the website that's now showing at the bottom of your screen. AAKP will keep you up to date about latest policy issues that affect patient care, and with one click, you will be able to contact your state representative, federal agency leaders, and many more who need to hear your perspective and your unique patient insights. Now, I'd like to introduce our session titled Vital Signals, Kidney Stakeholder Policy Priorities Impacting Patients. We're honored to have 4 individuals who are joining us who represent various organizations that work alongside the kidney community and other disease communities on important policy issues. AAKP is very interested in their perspectives and their views on issues of mutual concern. Now, I would like to introduce Michele Kimball, Executive Director of Kidney Care Partners, or KCP. KCP is a collaborative of kidney community professional organizations and industry partners. This organization operates under the leadership of AAKP's longtime friend and ally for greater patient care choice, Mr. John Butler, the CEO of Akebia. John shares AAKP's interest in patient access to safe, new care innovations, and also shares our determination that these innovations are reimbursed and paid for by CMS and other payers so patients have timely access. Michele, it is a pleasure to have you join us today. I turn it over to you.
Thank you. Hello, everyone. I'm Michele Kimball. I've been a patient advocate for my entire career, and as you know, I now serve as the Executive Director of Kidney Care Partners. Kidney Care Partners, or KCP as we are known, is the nation's largest nonprofit, nonpartisan coalition of more than 30 organizations representing patients, professional care providers, and a wide range of kidney care stakeholders. At KCP, we are working together to improve the quality of care, choice, and access for individuals living with kidney diseases. KCP members are committed to meeting patients' needs at every stage along the care continuum, and our diverse membership shares a broad vision across the full spectrum of the disease cycle, from education and prevention to early intervention, therapeutic treatment of chronic kidney disease and dialysis, and finally, to transplant and post-transplant care. Our policy priorities this year have focused on supporting patient choice and access in coverage options, treatment modalities, and innovative treatments and services. We've also been working to transform the Medicare ESRD benefit so that it moves dialysis care into a more patient-centered program. And we've been advancing quality to promote transparency and patient-centered decision-making, as well as working to ensure access to care for individuals living with kidney disease. As many of you know, chronic kidney disease is an illness that affects an estimated 37 million people in the U.S. That's more than 1 in 7 adults across the country, or nearly the size of the entire population of California. When you use that analogy, it is quite daunting how many people in our country are living with this disease. But despite the alarming statistic, investment in kidney disease research and therapies lags in comparison to other modalities. Sadly, our community historically has been among the lowest government investments in research and development and reimbursement for care. This impacts overall kidney innovation investment, which is reflected in the fact that we have historically had one of the lowest rates of new drug applications submitted to the U.S. Food and Drug Administration, particularly when compared to other therapeutic areas like oncology and cardiology. Some say this dates back decades to the lack of government investment in foundational and institutional research on kidney disease, tracing back actually to the National Institutes of Health, which has invested so little, despite the fact that kidney disease impacts so many, literally tens of millions of Americans. And looking at present-day payment, our largest reimbursement program, Medicare, provides little to no incentives or funding for investment in innovations or even earlier disease intervention. And while a program like KidneyX, a private-public partnership created with the U.S. Department of Health and Human Services to accelerate innovation, is a really good first step, and it gives much needed attention to this issue. A government investment of only $5 million is really just a drop in the bucket. So on one hand, we're seeing one department like HHS promoting programs like KidneyX to accelerate access to innovations. But on the other hand, the FDA is rejecting most of the drugs for kidney disease that it has reviewed in recent years. This, despite seemingly meeting trial study endpoints. And this is even for drugs that have been approved in other countries, such as Japan, South Korea, and throughout Europe. The FDA's puzzling rejections have prevented medications from reaching patients, further casting a pall over future investment. The FDA needs to closely examine whether it is applying the appropriate benefit risk assessment for new drugs intended for this population. So we must redress this imbalance, and we must address it right now. Patients can't wait. Unfortunately, such barriers to treatment end up affecting our most vulnerable populations, especially since kidney disease is more common among people at age 65 and older, in women, and in Black and Hispanic adults. According to the Centers for Disease Control and Prevention, Black individuals are nearly 3.5 times more likely than white individuals to develop kidney failure. This accounts for 35% of all of those with kidney failure, despite making up only 13% of the population. And Hispanic individuals are nearly 1.3 times more likely to be diagnosed with kidney failure compared to non-Hispanic individuals. As a nation, we have to address these inequities. The absence of sustainable long-term reimbursement for innovative treatments in the end-stage renal disease prospective payment system only worsens these inequities. So, this is why Kidney Care Partners is highlighting barriers to innovation and policy concerns that I know we share with AAKP. We are specifically raising issues relating to misalignments in payment and reimbursement policies that provide resources and incentives for innovations. KCP has long advocated for a sustainable long-term pathway to support innovation in the bundled Medicare payment system. This takes time. In the interim, we successfully recommended and advocated for the Transitional Drug Add-on Payment Adjustment, known as TDAPA, which provides a short-term pathway for adoption of new innovative products. It's a step in the right direction, but still permanent long-term funding is needed. KCP also recommended and worked closely with CMS to craft policies that add money to the base rate for certain new drugs. And now we are also focused on that important issue of CMS increasing payment rates after the TDAPA period ends. Earlier this year, a CMS request for information that we responded to was an important first step in defining the policy options that we are asking CMS to adopt in the 2023 rulemaking cycle. Hopefully, CMS agrees. Additionally, the Independent Nonpartisan Medicare Payment Advisory Commission, or MedPAC, that advises Congress along with our kidney community, has consistently raised concerns about the current ESRD PPS adjusters not being appropriately targeted to address higher cost patients, especially those with multiple disease conditions common among individuals with kidney failure. Fortunately, some leaders in Congress agree and have urged CMS to do just this. Senators Ben Cardin and Roy Blunt and Representatives Terry Sewell and Suzanne Delbene recently sent a bipartisan letter to CMS Administrator Chiquita Brooks-LaSure to address the Medicare prospective payment system and to not only adjust the payment rate when new innovative products are added to the payment bundle, but to most especially ensure the payment adjustment reflects the significant increases all of healthcare is experiencing in labor costs and workforce shortages. And KCP is also taking action. Our bipartisan community legislation, the Chronic Kidney Disease Improvement in Research and Treatment Act, would require CMS to review current reimbursement policies to assess these costs. Specifically, this bill would create an economically stable dialysis infrastructure and incentivize innovation by refining the payment system to improve accuracy in payment and support innovative therapies. The bottom line, for far too long, payments have been inadequate, and Medicare's ESRD program currently has no sustainable pathway to incentivize improvements in kidney care for patients. This needs to change now. As a community, we all know what the problems are, and we know what the solutions are. We have our ear to the ground on the front lines of care, and it's you, the patient advocacy community and leaders, who help guide us and inform lawmakers of problems and obstacles to patient-centric solutions. But it takes time, and it takes alignment of government actions and policies across HHS and CMS, the FDA, Congress, and other agencies for meaningful and measurable change and progress. We've got to all be in sync to deal with what I regard as a crisis, and it must be addressed yesterday. Why? You know this better than any of us. The fact of the matter is, kidney disease patients can't wait. They need access to innovative therapies to expand treatment choices and improve the quality of their lives now. Patients can't afford to lose access to treatment options due to a lack of investment in research, compounded by inadequate payment policies that actually disincentivize the development of innovative products and therapies. This is just wrong. The time for action is now. The nearly 40 million Americans living with chronic kidney disease are worth it and deserve access to the very best care. Fortunately, we have organizations such as AAKP and KCP who are on the front lines fighting the good fight and making a real difference. So I thank you for all you do, especially to educate our policymakers on issues important to all of us. And I am delighted to have had the opportunity to share some of these priorities and the focus of Kidney Care Partners with you today. Thank you.
Thank you, Michele. We appreciate you joining us and sharing your insights.